Hello, it's my pleasure to welcome you to this virtual scientific meeting developed by the American Neurogastroenterology and Motility Society, focusing on basic concepts in neurogastroenterology. My name is Beverley Greenwood-vanMeerveld, and I'm the immediate past president of the ANMS and current director of the ANMS Institute. The title of today's ANMS Symposium is Abdominal Pain, the Role of Visceral Organ Cross-Sensitization. And before we start, I'd like to thank all the members of the ANMS Planning Committee who have worked hard to develop the 2022 virtual sessions. And I'd like to ask you to please visit the ANMS website for further details on upcoming ANMS virtual events. I'd also like to share with you a date of an upcoming meeting. The 2022 clinical course will be in Philadelphia on August the 5th to the 7th. So please plan on registering and attending that meeting. And at that meeting, there will be a Young Investigator Forum, and the abstract deadlines for the Young Investigator Forum are April 1st. I'd also like to ask you to consider submitting your latest research to Neurogastroenterology Motility. This is the official journal of both the American Neurogastroenterology and Motility Society and the European Society of Neurogastroenterology and Motility. The journal is aiming to increase the number of papers it publishes in basic science research. So please support our society journal by submitting your latest research to Neurogastroenterology Motility. It has a 5-year impact factor of 4.4 and is free to all members of ANMS and ESNM. It's now my pleasure to introduce today's moderators, Dr. David Levinthal and Dr. Luke Grundy. Dr. Levinthal is an assistant professor in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh School of Medicine, and serves as the director of the Neurogastroenterology and Motility Center. He also co-directs the program for gut-brain health. Dr. Levinthal leads an active research program spanning clinical, translational, and basic science approaches aimed at understanding the neural basis of mind-body interactions and their role in determining states of gastrointestinal health and disease. We're also honored to welcome tonight Dr. Luke Grundy, who is a co-moderator at tonight's event. And Dr. Grundy is a research fellow at Flinders University in South Australia. And his research is focused on the mechanisms regulating bladder function and the development of novel pharmacology and drug delivery methods to treat chronic pelvic pain. Thank you both for co-moderating to today's event. And now I'd like to turn the program over to Dr. Levinthal.
Okay.
Thank you, David.
Yeah, thank you, Beverly. So it's my pleasure to introduce our first speaker for this webinar, Dr. Nick Verne. Dr. Verne is a professor of medicine at the University of Tennessee College of Medicine in Memphis, Tennessee. His research focuses on the neurobiologic mechanisms of altered motility and visceral nociception and functional GI disorders. Over the last decade, his laboratory has examined the aberrant non-coding RNA signaling pathways in IBS patients and animal models of visceral nociception. In addition, his group has studied the neurobiologic basis of gastrointestinal disorders in veterans with Gulf War illness. His current work is focusing on the use of small molecule modulators, mRNA mimetics and inhibitors, in vivo to develop targeted therapies for IBS patients. So it's really a pleasure to have Nick with us. Take it away, Nick.
Great, David. Thank you so much for that introduction. Well, this evening, we're going to talk about bowel-bladder interactions in irritable bowel syndrome. And what I want to try to get across is, look, is there a relationship between painful bladder syndrome and irritable bowel syndrome? So that'll be the theme of this first talk of this session. I have no disclosures. So the objectives of my talk this evening is first to discuss the presentation and diagnosis of painful bladder syndrome. Second, to review the clinical evidence for symptom overlap and interaction between IBS and PBS. And then third, to explore the common pathophysiology between painful bladder syndrome and IBS. So what is painful bladder syndrome? Well, we know that this is a chronic pelvic pain condition, also known as interstitial cystitis. It affects about 8 million women and 4 million men in the United States. The symptoms are frequently of frequent urination, increased urgency, and many of these patients, when we see them in the clinic, will have tenderness to palpation in the suprapubic area over the bladder. Now, one of the challenges with painful bladder syndrome, like we have with irritable bowel syndrome, it's a diagnosis of exclusion. There is no pathologic marker, so we have to use a constellation of symptoms and criteria. Often these patients will develop symptoms very slowly, not immediately. They can be insidious, where they'll have vague abdominal pain that can radiate to various areas. And as I mentioned, the physical exam, except for suprapubic tenderness, is often unremarkable. We do have some tests, cystoscopy and the Parsons test, that may help guide our diagnosis, and I'll mention those in a few minutes. Because of the difficulty in diagnosing painful bladder syndrome, the NIH had a consensus conference back in 2017. And NIDDK actually developed the following criteria. So for painful bladder syndrome, these patients need to have pelvic pain, pressure, or discomfort related to the bladder. And this is usually typically associated with persistent urge to void or urinary frequency in the absence of other infection or pathology. Now, a subset of patients with painful bladder syndrome will have interstitial cystitis, or IC. So these patients, by definition, also have to have bladder or urinary urgency. But in addition, on cystoscopy, one needs to see petechial hemorrhages or Hunner's ulcers. So this is just a classic cystoscopy findings that we see in a patient who has interstitial cystitis. On the left, you see petechial hemorrhages. On the right, you see the classic Hunner's ulcer. And this is pathognomonic for IC. And again, what these kind of are leading us to in this subset of patients is they have some type of injury to the bladder wall that leads to these findings. The other diagnostic test that can be used is the Parsons test. And this is where basically we infuse either saline or KCl in a randomized blinded fashion and look for the patient's response. If they have pain with KCl, that's considered a positive test. It suggests they might have increased bladder permeability. But as in a lot of our tests, the sensitivity specificity is not that great. And there's a lot of other chronic diseases that can actually have a positive test. So when we think about the difficulty in diagnosis, you can imagine the differential diagnosis for PBS is very broad. It includes urologic disorders, gynecologic disorders, and GI disorders such as irritable bowel syndrome. And that's the one that we're going to focus on the remainder of the talk and look at this overlap that we see. So the pathophysiology, I think, is very interesting in painful bladder syndrome. And I just wanted to spend a few minutes talking about that. This is a diagram that looks at the potential etiologies. I think that one of the unifying hypotheses that's strongest today is that there's some type of insult that occurs to the bladder. So this can be inflammation, trauma, overdistension of the bladder. This leads to a damage of the bladder epithelium, which increases bladder permeability and allows noxious materials such as mast cells, histamine, bacteria to infiltrate into the wall of the bladder where the myenteric plexus is, and this leads to an increased sensitivity of the peripheral nerves, which then cause an afferent barrage to the spinal cord, kind of setting up a chronic hypersensitivity or allodenic state. So the treatment for IC and PBS is also challenged, as we mentioned, imagining that we don't have a defined pathophysiology. I've listed the ones currently that are used for both PBS and IC. And if you look, the treatments that I've got here listed in blue, we also use for irritable bowel syndrome. So there's really considerable overlap. Behavioral modification, CBT, and even tricyclics. All of these have been used in irritable bowel syndrome too. So I think this also gives us a clue that because the treatments are similar, we have this significant overlap. So looking at the clinical overlap, I want to go through a little bit to kind of show some evidence in the literature that there is, these patients do have very much common comorbidities. If we look in the literature, in general, about 40% of patients who have PBS will also have a diagnosis of irritable bowel syndrome. Similarly, about 35% of patients who have IBS will also have a diagnosis of PBS. So this is one study I wanted to share with you. It was a very large study, 10,000 participants. It was an internet-based epidemiologic study where they had their participants answer both the Rome-3 criteria and the overactive bladder symptom questionnaire. And what they found is, which is very interesting, about 33% of patients who had a diagnosis established of PBS also had IBS. When we break it down by IBS subtype, about 50% of these were IBS mixed or alternating between diarrhea and constipation. I think the finding that was even more interesting is that if we look at the severity of the painful bladder syndrome, those that had more severe symptoms had worse IBS symptoms and vice versa. So it seemed like both the IBS and the painful bladder syndrome drive each other to increase overall symptom exposure. One other study that was actually just published last year that was really well done. This was in the VA healthcare system using the Vinci database. They queried the whole VA database between 1999 and 2016 and looked for a diagnosis of veterans with PBS using ICD-9 and ICD-10 codes. And they also looked for irritable bowel syndrome. And what they found is out of 872 veterans who had an established diagnosis of PBS, about 41% were male and about 59% were female. But I think what's really interesting here is if you look at about 200 or 23%, almost a quarter of these veterans who had an established diagnosis of PBS also had irritable bowel syndrome. And the ratio was about 30% of these were female and about 13% were males. So I think with that, I think this really gives us some strong evidence that there may be a common pathophysiology between these two disorders, given the overlap and also the comorbidity. So I want to just look at, this looks at visceral and somatic perception abnormalities. We know that from the literature that IBS patients, at least a subset, have decreased pain, have increased pain to colorectal distension. We see the same thing in patients with PBS. When they have their bladder distended, they feel pain at a much lower volume in comparison to controls. So if we look at the stimulus intensity curve, what's happening here is probably both in IBS and PBS, there's some type of insult that occurs either to the gut or perhaps the bladder, shifting this curve to the left where now normal distension pressures cause hyperalgesia or pain in both of these groups of patients. So if we look, what could be the origin and that what would be the potential possibility of why this is occurring? Well, certainly there's many hypotheses that have been out there. You know, many of them are actually also play a role in irritable bowel syndrome between, you know, alteration in central modulation, spinal thalamic neurons, and then also evidence for central sensitization, which is probably the most that has been written about, especially for the overlap of these visceral pain syndromes. So this just looks at two studies looking at visceral hypersensitivity. On the left is a study that looks at controls in IBS patients, showing that IBS patients have increased sensitivity to distension of the colon compared to controls. And this study on the right is from Tim Ness's group at UAB, where they looked at a group of patients with IC and did distension of the bladder and showed that compared to healthy subjects, patients with IC or PBS have increased pain sensation to distension of the bladder. Basically, their visceral thresholds are significantly decreased. Just similar to what we see in patients with IBS with colorectal distension. If we look at somatic hypersensitivity, over here on the left are patients with irritable bowel syndrome. And this is a subset that have increased sensitivity to both ischemic threshold and also to thermal threshold. Similarly, going back to Tim Ness's group, they've shown in patients with IC that they also have, patients have increased sensitivity to pressure testing with a handheld gaulometer. Shown in this graph here, the trapezius, masseter, and ulna are all more sensitive, and also increased sensitivity to the ischemic threshold or tourniquet test. You can see that these patients have much greater ratings, can tolerate this test a lot shorter period of time compared to controls. So how might all this play a role in setting us up for understanding this unifying pathophysiology? Well, this I put together here, this is a model of convergent input into the spinal dorsal horn neurons. With our patients with irritable bowel syndrome, we have pain, obviously, afferent impulses from the colon going to the dorsal horn neuron. Similarly, patients with painful bladder syndrome have the same thing, these painful impulses from the bladder going to the dorsal horn neurons, leading to dorsal horn neuron sensitization. This then obviously travels up the spinal thalamic tracts, leading to increased pain and potentially central sensitization in the central nervous system. And this just kind of summarizes what may be happening between in these groups of patients. This top panel looks at what happens in normal conditioning. We have in a normal patient without any disease, we have a nociceptive pain input. And basically these brief nociceptive impulses are regulated and they do not lead to central sensitization. However, if we look at patients with painful bladder syndrome or irritable bowel, when we have a similar nociceptive input to the spinal cord, these patients have probably some type of dysregulation of both ascending and descending modulation, leading to the abnormal sensation of pain. So in conclusion, I think it's fair to say, based on what we see in the literature, that IBS and PBS have similar altered visceral somatic perception to nociceptive pain stimuli. There is evidence in both groups for central sensitization and altered central pain processing. So the question becomes, setting us up for our next talk, is do PBS and IBS share a common mechanisms of visceral organ crosstalk? Thank you, and I will turn it over to our next speaker.
Great, thank you very much, Nick. That was a fantastic introduction to this session. It gives me great pleasure now to introduce Dr. Greenwood-vanMeerveld, who completed her PhD in 1983 at the University of Sheffield. She then gained postdoctoral training from the University of Calgary. In 1986, she moved to the Medical College of Wisconsin as an assistant professor of pharmacology and toxicology. And after holding a research position at Eli Lilly and Company, she moved to Oklahoma to become the scientific director of the Oklahoma Foundation for Digestive Research. In 2003, Dr. Greenwood-vanMeerveld moved to the University of Oklahoma Health Sciences Center as the director of the Oklahoma Center for Neuroscience and Presbyterian Health Foundation Endowed Chair in Neurosciences. Upon her retirement in April 2021, Dr. Greenwood-vanMeerveld was a prestigious George Lynn Cross Professor of Physiology, a presidential professor, and a senior VA career scientist. Dr. Greenwood-vanMeerveld was actively involved in research upon her retirement and was serving as the PI on an active NIH R01, a VA merit grant, an OCAST grant, and numerous industry contracts. Dr. Greenwood-vanMeerveld's research expertise is in the neuropharmacology of visceral pain of gastrointestinal, and it gives me great pleasure to introduce her here for this talk.
Thank you, Luke. Okay, well, yes, thank you, Luke, for that kind introduction, and thank you to the NMS for inviting me to give this presentation today. So my plan over the next 15 minutes is to share with you what we know about the mechanisms underlying visceral organ crosstalk. From Dr. Verne's lecture, you heard very nicely about this, these commonalities between irritable bowel syndrome and bladder pain syndrome. The clinical presentations of chronic visceral pain are similar. In IBS, there's altered bowel habits and urgency and relief upon defecation. Whereas in bladder pain syndrome, there's frequent urination and urgency and relief upon urination, Both disorders are female predominant. And as Nick shared, patients with IBS are often diagnosed with comorbid bladder pain syndrome, and 40% of patients with bladder pain syndrome fulfill an IBS criteria. And although I'm going to be focusing on IBS and the bladder and the colon in bladder pain syndrome, I want to be sure that we are all aware that there are many other examples of visceral organ crosstalk between the duodenum and the pancreas, between the heart and the esophagus, between the prostate and the bladder. But we're going to be focusing on the bladder and colon tonight. So in light of the clinical work and research that you heard from Dr. Verne, animal models have been very helpful in determining the underlying pathophysiology of visceral organ crosstalk. And there are rodent models of cystitis in which protamine sulfate, potassium chloride, or cyclophosphamide are infused into the bladder. And then subsequently, it's shown that these animals also exhibit colonic hypersensitivity to colorectal distension. And conversely, in a rodent model of colitis, with inflammation of the colon with TMBS, this alters bladder function both in vivo and in vitro. And taken together, these findings suggest that these coexisting comorbidities between the bladder and the colon may result from persistent and enhanced neuroplasticity in the sensory pathways innervating these visceral organs. And this is a slide that Dr. Verne showed briefly in his presentation. But just to reiterate and build upon what he shared with us, there are 3 levels of the nervous system that are likely involved in visceral organ cross-sensitization. At the periphery, injury or inflammation can damage an organ, and this can lead to pain in an adjacent organ. And it can do this through increases in afferent fiber discharge, decreases in excitation threshold, and even activation of silent nociceptors leading to allodynia and hyperalgesia. The spinal cord and dorsal root ganglia are also thought to be involved in visceral organ cross-sensitization. Convergent DRG and spinal neurons that receive input from the bladder and colon, leading to prolonged dorsal horn neuronal firing, decreased dorsal horn excitation thresholds, and neuroplasticity within the spinal cord and DRG associated with changes in BDNF, microglia, for example. And also the 3rd level of control is the brain. There's evidence to support the rostroventral medulla in visceral organ cross-sensitization, the thalamic regions, the cortical regions, and some data that I'll present tonight on the amygdala. So it was our hypothesis when we began these experiments that abnormalities in intestinal and bladder permeability may be responsible for visceral organ crosstalk. We thought that increased permeability in a damaged visceral organ may lead to heightened permeability in a distant, undamaged visceral organ. And the work that we did to support that hypothesis, where we instilled protamine sulfate into the bladder, and this was done to irritate the bladder. We actually used a low concentration of protamine sulfate. And in these animals, in the bladder, we didn't see any gross or overt histology, but we did see that there was an increased permeability of the bladder, as shown here in purple, where we looked at the permeability of the bladder using transepithelial electrical resistance as an electrophysiological marker of permeability. So if the resistance goes down, we are showing that the permeability will likely have gone up. And we were able to see that protamine sulfate increased permeability, not only in the bladder on 1 and 3 and 5 days post protamine sulfate in the bladder, but we also noticed and measured a decrease in transepithelial resistance in the colon at 1, 3, and 5 days following the protamine sulfate infusion into the bladder. So what is this relationship between intestinal permeability and visceral hypersensitivity? A transient visceral organ, such as the bladder or colon, if you damage it, the visceral organ then we're suggesting becomes permeable, contents leaks out, and then bacteria, inflammatory agents can activate afferent fibers, innervating that visceral organ. And to support that idea, we actually looked at protamine infusion, and we're able to show that induced persistent colonic hypersensitivity. What I'm showing you here is colonic hypersensitivity assessed via a visceromotor response to colorectal distension and quantified as the number of abdominal contractions in response to graded pressures of colorectal distension. And you can see in purple that at 1 day following the protamine sulfate infusion into the bladder, we saw an increase in the number of abdominal muscle contractions in response to colorectal distension. And this persisted through days 3 and day 5 post-infusion of protamine sulfate into the bladder. In these same experiments, we also looked at whether protamine sulfate infusion into the bladder increases spinal neuronal activity to colorectal distension. And here we measured p-ERK expression in the dorsal horn of the spinal cord. And in the histograms on the right-hand side of the slide, we see that in sham-treated animals, there was an increase in the average number of p-ERK immunoreactive neurons, but in animals treated with protamine sulfate, days 1, 3, and post-protamine sulfate, there was an increase in p-ERK containing neurons at all 3 time points. So in summary, I've shown you so far that experimentally induced bladder permeability increases the sensitivity of the undamaged colon via hyperexcitability of spinal ascending neurons converging in the dorsal horn of the spinal cord. And this preliminary data reinforces the notion that changes in permeability and spinal hyperexcitability may represent a novel mechanism for visceral organ sensitization and may be important in the overlapping symptomatology of IBS and bladder pain syndrome. And we use this model to actually look at whether guanylate cyclase C activation plays any role in reversing bladder-colon cross-sensitization. And this is data from the colon. Once again, we use transepithelial electrical resistance as our marker of changes in gut permeability. And here I'm showing you in vehicle-treated animals, sham vehicle-treated animals versus vehicle-treated animals with protamine sulfate. There's a decrease in the TER that is reversed by linaclotide. And similarly with conductance, the increase in conductance is reversed by linaclotide. And when we looked at the visceromotor response to colorectal distension, we see the exaggerated response in protamine sulfate treated animals and a reduction or attenuation of that response in animals treated with linaclotide. We also built upon that work using p-ERK expression, and we were able to show in 3 regions of the spinal cord that the elevated p-ERK expression in animals treated with protamine sulfate was reversed by pretreatment with linaclotide. So these results show you that infusion of protamine sulfate into the urinary bladder increased permeability, as illustrated by decreased transepithelial electrical resistance and an increase in conductance, not only in the urinary bladder, but also in the undamaged colon. And the linaclotide was found to reverse these changes in colonic permeability and spinal nociceptor signaling in response to protamine sulfate infusion into the bladder. We also know that early life stress serves as a risk factor for visceral organ hypersensitivity. Early life stress increases the likelihood of developing brain gut disorders and bladder pain syndrome in adulthood. And females diagnosed with either of the disorders frequently report prior early life stress. And this may make them more susceptible to the negative effects of VLS, suggesting some sexual dimorphism here. And what we did in the lab was we developed a rodent model in which we exposed them to early life stress. It was a predictable or an unpredictable early life stress. And then in adulthood, we looked at colorectal sensitivity. And we found that in female rats in adulthood previously exposed to unpredictable early life stress, there was a visceral hypersensitivity. Interestingly, in male animals, we did not see a phenotype. And going back to the female animals, we were able to attenuate the visceral hypersensitivity in response to unpredictable early life stress by ovarectomy. And then estradiol replacement was able to reinstate that exaggerated visceromotor response to colorectal distension in those female animals. We then took this model and looked at colonic and bladder hyperalgesia in response to ELS. And we were able to show that in animals treated with unpredictable early life stress, in adulthood now, they showed an exaggerated visceromotor response to colorectal distension. And if you focus your attention on the bladder, we also saw an exaggerated bladder average number of bladder withdrawal responses indicative of bladder hypersensitivity. And in both the colon and the bladder, the linaclotide attenuated the colonic hypersensitivity and the bladder hypersensitivity. We were also able to look at hyperpermeability in this model. The colon, in the colon from animals exposed to unpredictable early life stress, in adulthood, they had a decrease in transepithelial resistance and an increase in conductance that were reversed by linaclotide. And similarly, in the bladder, animals exposed to early life stress had a decrease in transepithelial resistance that was reversed by linaclotide, and the same with conductance. So far I've shown you that unpredictable early life stress leads to visceral organ hypersensitivity in adult female rats, and activating peripheral GCC signaling with linaclotide significantly reduced colonic and bladder hyperalgesia and reversed barrier dysfunction in adult female animals previously exposed to neonatal ELS. There's also evidence for altered central processing in patients with IBS, as Dr. Verne pointed out. And this may also be involved in visceral organ cross-sensitization. And this is some work looking at fMRI and PET imaging and the importance of differences in the amygdala between control and IBS patients. So we took this information to ask the question, does sensitization at the amygdala play a role in visceral hypersensitivity following ELS? And we hypothesized that unpredictable ELS alters glucocorticoid receptor and CRF expression within the central nucleus of the amygdala to drive visceral hypersensitivity in adult female rats. We looked at glucocorticoid receptor expression and CRF expression in the central nucleus of the amygdala. And interestingly, we found the expression was determined by the early life challenge, whether it be predictable or unpredictable early life stress. And interestingly, following predictable early life stress and unpredictable early life stress in adulthood, glucocorticoid receptors were increased in the central nucleus of the amygdala, but it was only following unpredictable early life stress that CRF levels were increased in the amygdala. We built upon this work by looking at whether if we could attenuate visceral hypersensitivity in adult rats following unpredictable ELS using CRF antisense oligodeoxynucleotides and comparing that data with random sequence ODNs. In the random sequence ODNs shown on the left-hand side, you see that visceral hypersensitivity following unpredictable early life stress. And we could abolish that with the CRF antisense oligodeoxynucleotides placed directly into the central nucleus of the amygdala of adult animals. We also built upon that work showing that a selective CRF1 antagonist infused directly into the amygdala was able to attenuate visceral hypersensitivity following unpredictable early life stress. So in summary, I've shown you that central sensitization at the level of the amygdala plays a pivotal role in visceral organ cross-sensitization in response to life stresses. I've shared with you that 3 levels of the nervous system are involved in visceral organ cross-sensitization: the periphery, the spinal cord, and the brain. Before I end, I'd like to acknowledge my team, as well as the funding from the Department of Veterans Affairs, OCAS, the NIH, and Ironwood Pharmaceuticals for supporting the research I presented today. And most of all, I'd like to thank you and the ANMS for attending this event. And I'll turn the presentation back over to David. Thank you.
Well, thank you, Beverley, for a tour de force of your research bearing on this really important issue. That was fantastic. Thank you. I want to remind the audience that if you have a question for any of our speakers, use the question and answer box. We have one question currently asked. You can accumulate these questions. We'll deal with the questions in an open forum at the end of our next talk. So please enter those questions as you have them. It's my pleasure to introduce our next speaker, Jose Garza. He's the medical director of neurogastroenterology and motility at Children's Healthcare of Atlanta. He's a partner for a large Atlanta-based private practice group, GI Care for Kids. And he's the co-director of the Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Healthcare of Atlanta. He brings a welcome pediatric perspective to this conversation about organ crosstalk. And it's a pleasure to have you. So thank you, Jose.
Thank you very much. Hello, everybody. It's a pleasure to be talking to you today. Thank you for joining us. I'm going to talk about this comorbidities between the bladder and the bowel in pediatrics. These are my disclosures that have no relevance to this talk. The worldwide pooled prevalence of functional constipation in children is about 9.5%. And it was interesting to see that daytime urinary incontinence in children is a lot more frequent than functional constipation, about 10 to 17%. The lower urinary tract symptoms that have been associated with GI diseases are the overactive bladder, enuresis, voiding postponement, stress incontinence, dysfunctional voiding. The gastrointestinal comorbidities to these, including the constipation and fecal incontinence, can reach about 22 to 34%. So what can explain this frequent comorbidity? Well, three things. One, shared developmental origin. Two, close anatomical proximity, and the pelvic organ crosstalk. So let's talk about each one of these. The shared developmental origin makes sense as they were once one. The cloaca that got divided into the urogenital sinus and the anorectal canal. And by doing this means that all the innervation is going to be similar, if not the same. When we look about controlling of the external anal sphincter and the external urethral sphincter, the pelvic floor motor neurons are located in the nucleus of Onuf, which is in the anterior horn. And this actually cannot contract this muscle separately. This is like an Atari controller. There's only one button. So you cannot squeeze one without squeezing the other one. And also, because they are straight muscle, you cannot continuously keep contracting them. Eventually, you'll come urge incontinence. So how does micturition happen? So part of the process is there is a periaqueductal gray that receives the information for how much pressure is in the bladder. This gets sent to the cortex, which then has the perception of the bladder fullness. And then based on our environment, we're going to decide whether it's okay or not to proceed with micturition. And when it's okay to proceed with micturition, we're going to remove the inhibition of the Barrington nucleus, that way being able to produce micturition. So the bladder gets distended, is increased pressure, the cortex senses this increased pressure, and the moment that it's socially acceptable to do this, then we remove the inhibitory influence of this Barrington nucleus, also called pelvic organ stimulation center or pontine micturition center. Once we remove this inhibitory influences, then we can have this sacral reflex arc that produces the trusor contraction, increase in the pressure, accompanied, of course, by a voluntary relaxation of the striated external sphincter. It is very similar what happens with defecation. When we have that distension of the rectum, there is not only the reflexes of the rectoanal inhibitory reflex, but there is a rectoanal contractile reflex that happens through the Onuf's nucleus. And also at the same time, we become conscious of the need to defecate, and we need to turn the inhibitory effect of the Barrington nucleus to actually produce defecation. So how about the next issue, which is the anatomical proximity? So both organs are positioned close to each other, and they both have similar function, which at the end of the day is storage and evacuation. We see this often in pediatrics. We have this huge mega rectum impacted with stool that compresses on the bladder, creating changes in the bladder sensation and in the bladder function. Because the state of the rectum is going to influence the handling of sensory information from the urinary tract and vice versa. In animals, when you do rectal distension, it's going to inhibit bladder contractility. This is opposite of what happens in humans, but we have to understand that most of the animal models are acute in nature versus our patients require chronicity and recurrent disease to seek medical attention. In humans, especially adults, this rectal distension is stimulatory. So it's going to cause a decrease in bladder capacity and an increase in contractility. What happens in young, healthy women? So there's even changes between the bladder and bowel when you are even in health, when you have a full rectum or not. So when your rectum is full and distended, the sensation of the bladder are going to be observed at smaller volumes. And that rectal distension is going to reduce the maximum bladder capacity. But it also works both ways. If you have an empty urinary bladder, you're going to have less desire to defecate at rectal distension. And if you have a full bladder, you're going to have increased rectal urgency. So one affects the other. What happens in children? Well, in children, the response is individualized and it's unpredictable. So filling the rectum can cause either stimulation, inhibition, or absolutely no changes in bladder function. And one would think that this is dependent on the underlying pathophysiology, but it's unrelated to clinical diagnosis. Even if you had constipation or not, it's not going to predict your response to the rectum. And other than close proximity and origin, we need to talk about cross-organ sensitization, which has been talked in the previous two talks. And it's when a disease of one organ results in the development of pathology in an otherwise unaffected adjacent organ. So this crosstalk happens when there is this transmission of this noxious stimuli of this affected pelvic organ to the adjacent normal one, creating functions in the latter, which eventually results in peripheral sensitization that leads to central amplification in the spinal cord and brain. So this sensitization has been talked before. It's not only neural mechanisms, but has endocrine, paracrine, and immune responses. The hormonal status actually sets this background for changes, and there's different effects based on the level of estrogens, which could explain that sex difference. But we have to understand the limitations, especially in pediatrics, when we talk about rat models. So what this guy's not telling you is that they don't stop normal activity to defecate. They just keep on doing what they're doing. And they don't need to adopt a defecatory posture in contrast with humans. But it's important to understand that early life events and what happens in childhood does impact what happens in adulthood. Because the nervous system is going to develop early in life. Any interventions, good or bad, can affect the structure and connectivity later on. When you see women with interstitial cystitis and bladder pain syndrome, they report having a higher incidence of childhood UTI. And it makes sense that if you're not comfortable and have pain with urination, you develop negative conditioning and problems with behavior. To the point that children that have bedwetting have significantly increased rates of psychological problems, as well as those with fecal incontinence. But it's interesting that is it the incontinence that leads to the behavioral problems or the behavioral problems that leads to incontinence? Because what is the chicken, what's the egg? In some patients, you can treat the behavioral problems and the incontinence gets better. And in others, you treat the incontinence and the behavioral problem gets better. And it's interesting because there is a behavioral and psychological process to urination and defecation. And in this paper, patients that had non-retentive fecal incontinence and compared to children that were controls, you can tell that there is a difference in sleep and in plasma orexin A levels. And orexinergic system is not only good for sleep, but it's also good for sphincteric control. And it turns out that sleeping and orexin have to do with voiding because, for example, voiding in the neonates and infant, it's actually related to the sleep cycle. And 90% of neonates and infants will eventually awaken for sleep in the immediate preceding micturition. So it turns out that this Barrington nucleus or pontic micturition center is pretty close to the locus coeruleus, and it receives a lot of information from our central nervous system to actually decide on our sphincter control. And we cannot deny that there is an actual emotional process to urination and defecation. Why? Because the PAG that we talked previously actually inhibits or releases the inhibition from the pelvic pontic micturition center, receives information from the amygdala, from the cortex, and from the hypothalamus. And this is why when you really need to use the bathroom and you're holding and holding and holding and finally make it, the moment you get closer, that feeling intensifies. Why is that? Because the frontal cortex starts seeing that you are in a safe place so you can start relaxing. I think this makes also evolutionary sense, right? If you were chased by predators, you don't want to stop and urinate or defecate. So it understands that by feeling safe and understanding emotions has to go with how easy you can actually remove the inhibition or not remove the inhibition. But we also can't deny that the pathophysiology of functional constipation that we can see in this slide, it's pretty similar to the pathophysiology of bladder problems. And at this point, if you treat a bladder problem, you can also treat a constipation problem. So behavioral modification of sitting and understanding your body can actually treat a good percentage of children. But it's not a perfect correlation. This does not all explain the comorbidity, right? When we look at urinary incontinence and we look at girls, 7-year-old girls have a high incidence of urinary incontinence and compared with 70-year-old boys. And when you flip it and look at fecal soiling, it's the opposite. We have a higher percentage of boys having fecal soiling compared to girls. And when you look at the urologic literature, they say that over 50% of patients with lower urinary tract dysfunction have actual bowel dysfunction, calling this bladder and bowel dysfunction. But there's a little bit of a problem with this because in all of these patients and papers, how is constipation diagnosed? And I have a problem because I don't believe in silent constipation. I don't believe that constipation should be bestowed upon the patient. It should be complained by the patient. And a lot of these papers use an abdominal X-ray to diagnose constipation. And it's important to understand that constipation needs to be diagnosed by history and a physical exam, utilizing, for example, the Rome criteria. So when you look at these patients with bowel and bladder dysfunction and they undergo their treatment, you can see that before treatment, 17 had constipation, and after treatment, 14 had constipation. And 57 had fecal incontinence, and after treatment, 38 had fecal incontinence. But they were not the same that actually got better. Some got better, some got worse, and some stayed the same. A lot of the ones that have a similar pathophysiology, like an outlet dysfunction, makes sense that all of them are going to get better. But some of them, they don't change or they can get worse. And when you compare those patients that have only constipation, those that had constipation and urinary symptoms, and the control group, turns out that they're different. For example, those that constipation behave like controls when we look at urine problems. Those patients that have urinary problems have decreased voiding volumes and increased residues. But when you look at the pelvic function, and it makes sense because we talked about one controller, those patients with constipation urinary problems have that pelvic floor muscle activity very similar as opposed to controls. So one would say, well, maybe this constipation patients, as they get older, then they get worse, so that rectum gets more distended, affecting the urinary tract, creating now urinary problems. But that doesn't pan out. This same study compared the rectum diameter of those patients with constipation versus those with constipation and urinary problems, and they're no different. They're both different than controls. So it's important to understand that definitely a temporary fecal mass in the colon, even in healthy people, are going to affect how we process and how we feel urination. But it's interesting in this paper, 54% of patients that were in pediatrics, once you deflate the balloon, the symptoms got reversed. But there is a percentage of patients that 46%, despite of deflating the balloon, whether it was a change to stimulatory or inhibitory changes, those persist after balloon inflation. So these are clearly different patients that are a little bit more responsive to what's happening in the rectum with the bowel, with the bladder. So when constipation is associated with lower urinary tract symptom, I think constipation should be addressed first because there's a good chance it's going to get better. One, we need to treat constipation. Two, fecal impaction does affect bladder function. And three, there is a common treatment between the two. But we have to understand that not all the time that you have a patient that has bladder dysfunction is going to be because of bowel. Yes, there are numerous etiologies, but constipation doesn't necessarily need to be there 100% of the time. So when we talk about bowel and bladder dysfunction in pediatrics, behavior and slow urine withholding, definitely a relationship. Shared developmental origin, definitely a relationship, as well as a close anatomical proximity. As for pelvic organ crosstalk, we need further research and also further research interesting in this orexigenic system in whole in sphincter control and incontinence. So with that, thank you very much.
Brilliant. Thank you very much, Jose. That was a fantastic talk. And thank you to all the speakers for their contributions today. This has been an absolutely wonderful session. So we'll now open this up for questions. And I'd like to start by reading the first one out of our Q&A panel. So it's directed to Nick, but I think if any of the speakers have some insight into this, then please jump in as well. And the first question is, what is known about the role of local or gut inflammation in bladder pain in humans? So does anyone have any experience in sort of correlations there?
I'll take initial stab at it. You know, there's not a lot out there in the literature. I mean, I think the one area is patients who have inflammatory bowel disease. There has been some suggestion that they may also have inflammation in the bladder or increased permeability. But again, just a few small, nothing really hasn't been really well studied, but I think there probably is an association.
Anybody else have a comment on that? Okay. So another question that was posed, are there therapies for interstitial cystitis, painful bladder syndrome that we can adapt for patients with IBS? I think Nick, you had brought up a little bit of a kind of a slide with similar therapies, but is there something we can pull that might be unique from the IC PBS world into IBS treatment? That's a question for anybody.
I'm not familiar with any. Luke, do you happen to know if there's any therapies for IC and PBS that could be used for IBS patients?
I don't know. I mean, to be honest, there's not really too many effective treatments for IC PBS, as we know anyway. I think really the most effective treatments have been those that target the bladder sensory nerves. But the problem with those is that they're not really long-term in nature. So we know that if you infuse things like lidocaine into the bladder, you get sort of immediate relief of painful bladder symptoms. There was a paper looking at neosaxitoxin, sort of essentially a voltage-gated sodium channel inhibitor, had very good clinical effect. But these things involve an invasive treatment of essentially catheterizing the bladder and an infusion. So I think we know that those similar treatments would impact the gut, but I don't think there's anything really fundamental that has been shown mechanistic wise for painful bladder syndrome that could be translated at this stage.
Thanks. I think the other direction is sort of interesting, though. From the preliminary data that we obtained, you can take a drug that's effective in patients for IBS, and then in an experimental model of visceral organ crosstalk, where we have a bladder abnormality, we were able to use that IBS therapy to help treat potentially the animal or the patient with a bladder problem. So that's something sort of interesting, that you can use an IBS therapy to break that cross communication between the colon and the bladder.
Yeah, and one other area, Beverly, you brought up, is that maybe intestinal permeability. If you treated the increased permeability in the IBS patients, it may affect the permeability in the bladder too, potentially.
Yeah, if it's the heightened permeability that's driving that visceral afferent sensitization, and clearly we're seeing, you know, if in either model, if for example in the TMBS model where we have enhanced permeability in the colon, and there's clearly an enhanced permeability in the undamaged bladder, and vice versa, you challenge the bladder with protamine sulfate, where we know there's no gross inflammation, and that led to an enhanced permeability in the colon, which we haven't touched. It's completely, you know, undamaged and hasn't been manipulated.
Great. So I guess we'll move on. There's quite a few questions here, and I think we're quickly running out of time. So I guess one of these is, how about crosstalk between, you know, other syndromes, other chronic diseases, sort of chronic fatigue and fibromyalgia, along with things like IBS and bladder pain?
Well, we know that crosstalk exists based on animal models and based on clinical data. I mean, Nick, in your patients that present with IBS, do many of them complain of fibromyalgia?
Yeah, there's a significant overlap. You know, one of Dr. Moshri, when she worked with us many years ago, published a nice paper showing IBS plus fibromyalgia patients, and the similarities having both thermal hypersensitivity and also visceral. So there was significant overlaps between those groups, yeah. But what drives that, I'm not sure.
Well, in our rodent models, what we often see, we can induce a visceral hypersensitivity. If we then look at somatic sensitivity, we also see somatic hypersensitivity that occurs simultaneously with visceral hypersensitivity. And that fits sort of with the patient population with visceral and somatic hypersensitivity, demonstrated by fibromyalgia and IBS. Anything in children there you could share with us, Jose?
No, I think that in everybody, once you have central sensitization, especially in the spine, where the nerve fibers of visceral are more tightly packed, there is a easier way of actually sensitizing other organs and other areas on a patient that already has probably, you know, the gene predisposition to have this visceral hyperalgesia, chronic pain, even, you know, kind of hypervigilance and all that process. So I think the pathophysiology, it's probably pretty similar, and it just, you have a genetically predisposed individual, and depends on the early life events and when you have enough of those sensitizing events that actually eventually cause that process.
Yeah, that's a good point. I mean, when it's at the cortical level, at some point you're probably less labeled line, more diffuse organ systems involved. I think we're getting to the end of our time here, and there are a lot of great questions in the Q&A, and I want to assure everyone that's been really good to bring up these questions to our speakers tonight. And any questions that we didn't address in this session will be brought up on Doc Matter, which is the platform for ANMS members to interact. And we'll continue that conversation, taking some questions from the audience and putting those questions on Doc Matter. So stay tuned for that. I really want to thank all of our speakers tonight and everyone for attending. This was a fantastic session, and really a great overview of a really important topic that has a lot of bearing on our clinical work. So thank you to our speakers and to ANMS for sponsoring this talk.